So we are going to start. Welcome to this session. We are going to have two conversations in this room. We'll start off by talking about caring for the carers, and then we'll move on to integration best practices. This afternoon, we are joined by three panelists for the caring for the carers session. I'll ask each one of them to introduce themselves so that they can say a little bit more about themselves. So we'll start off with Dr. Mombi. Maybe you can just introduce yourself.
Hello, I'm Dr. Mombi Chege, psychiatrist. I was born in Nairobi. I'm the last born. Which part of me do you want to know about? And I'm the mental health focal person for Kiambu County.
Hi, I'm Kennedy Micheni. I coordinate mental health issues, related issues at Changamoe sub-county. Thank you. Oh, I'm the last born in a big family. Thank you.
Okay, I needed to hear that because I'm a last born in my family. Yes, I'm the baby of my mother, and my mother is about 90. And when I go home, I'm treated like a baby. Imagine. Oh, my name is Jane Thieme. I was so excited to be in the midst of last borns because we are allowed to misbehave. Thank you. I work as Associate Director in charge of GBV and HIV prevention. Above that, I'm a counseling psychologist.
Thank you so much. As you heard, our panelists are people who have really done quite a lot in terms of mental health work, and each one of them has an expertise in some area, and today we'll be engaging them, and they'll be telling us their perspective of caring for the carers. As we are aware, we are always talking about the person who is getting cared for. In the morning, we've heard a lot about the clients who have been able to access services, the service provision models, the policies. We've heard quite a lot about that. But I haven't heard anyone talk about the carer. And we all know when all this happening, when all these things are happening, the person who is taking care of the person who is experiencing a mental health condition could be going through quite a lot. And sometimes they have to be the one that is putting up the strong face so that the person that they're taking care of feels that they're not becoming a burden. So our panelists today are going to delve deeper into that topic, and I'll be asking them a few questions, and then I'll allow you to also ask questions. So I'll start off with Jane Thieme, and Jane, I know, is a seasoned psychologist, very passionate about mental health, and recently her passion has started becoming caring for the carers. So Jane Thieme, in your work over the years, I know you have met people who have had the burden of taking care of people who are living with mental health conditions, both from the family perspective to the community perspective, all the way to the health facility. So we're going to be looking at what are the issues that are affecting people at family level, what are the issues that are affecting people at the community level, and even what are the issues that are affecting people at the facility level. And these are the people who are caregivers. So what are some of the things that you feel they could be experiencing based on your practice and experience?
Okay, thanks, Stella. I think when you look at a carer whether in the hospital as a nurse or whether caring for somebody who is sick, is that sometimes people do not know what you're going through. There's a sense always when you're taking care, and particularly if you have a sick person or you have a person with mental health issues, even as you look at other people, you think they don't know what you're going through, and nobody knows exactly what you're going through because we don't understand. That is the first thing. And there is a sense of isolation because you're always with the sick person. So you don't get to engage in the social activities, the demands of the sick person as you watch your person going from most of the time the people we care for, rarely are they taking an upward trend. They are sick, they are expensive to manage, so it becomes very hard. And there's that sense of isolation, there's that sense of people have deserted me, and there's loneliness. There's loneliness, and even when you try to engage, even when you go to church, and I've seen even friends who have people they are taking care of, they come to church and they are just disconnected because they are thinking what is happening back at home. So this is a person who is in their own special space that needs to be taken care of by the rest of us who are not in that circumstance at that point.
Thank you so much, Jane. And maybe moving on the same conversation, Ken Mireti, I know you are coordinating mental health services in Mombasa County, in one of the sub-counties in Mombasa. And one of the issues that really comes up is the coordination between the caregiver and the service providers. So you find that sometimes the service provider does not communicate very well on what is required for the person who is being taken care of. And then now this becomes really a burden for the caregiver. So what are some of the things that you'd be suggesting that we can do to improve, or what some of the things, the systems that we can put in place so that we improve the collaboration and the communication between the caregiver and the service provider, so that we really do not put the burden on the caregiver? Thank you.
Thank you for that question. Actually, you find that between the caregiver and the service provider, there should be proper communication, constant communication, and in order to achieve, or rather to enable the continuation of services, you find that, for instance, someone who has a mental health issue has been seen at the facility, and this person has to go back to the community. So it is good from the beginning, from the facility level, let there be proper communication to the caregiver, because someone who is mentally sick cannot make decisions. So it's upon now for the caregiver to stand in for this person. So if proper communication is not done, then it means actually you won't achieve. So in that way, we need to engage the caregivers, give a proper instructions. If need be, let the family and the community be involved, so that actually this client can get the best service ever. And in this, you find that we can also attach this caregiver to a support group. Or rather, we have also, like now in this country, we have CHPs. And these CHPs are from a community unit. And we find that they are from the communities, down to the communities. So you find that I think it's good that we attach the caregiver to the community CHPs or the healthcare providers who are at the community level, so that they can have that support. They can also be checking in on the progress of the client. I think in that way we'll have a good referral system, whereby we refer the client to the facility, at the same time we refer them back to the community, but let there be a proper channel and proper communication. Thank you.
Thank you so much, Ken, and I think I agree with you, strengthening the communication and also strengthening the referral pathways and also creating support systems for the caregivers, both at the community and the facility level. Dr. Mombi, I know you are leading the mental health agenda in Kiambu County, and probably you'd want to share your experiences in terms of what support is given to ensure the well-being of the mental health providers within your county? Thank you.
Okay. So, mental health services in the country, and I'll speak more so about Kiambu, benefited from the pandemic because suddenly there was a big drive, there was a universal drive for mental health support, psychosocial services support, and because of that, there are a lot of programs that were started during COVID time for support for the frontline workers. Ever since then, there has been active debriefing, at least now a lot of facets of government services came to know that there is psychosocial services support. So now the police occasionally will call us and they'll tell me, we need to debrief the child health officers, the workers, and then we'll need, the social workers need a session. So ever since that point, over 2,000 workers at different aspects, from the security to the administrative, even the chiefs have called us. The teachers have called us, the health workers, the county assembly, we've had sessions with them. So different facets of government workers have benefited from access to psychosocial support, psychosocial debriefing, and then now once they have, because once you have seen that the sub-county liaison came with a psychologist from the sub-county, then you know within my sub-county there's this for health workers, mental health workers. So now I know, as much as I'm a dreams mentor, I know within Kianjoro there's this person, right? So we actually benefited quite a lot from just the structures were set up at that point. And since then, as much as the funding may have reduced a bit, the workers are still as passionate, they're still as experienced. So those resources stayed within the county, and the county has been benefiting in that aspect. Just to note, I really like what you said about the CHPs. I work at the consultant level, the institution level, but it's good for now, I can actually take back what you said, the CHPs to the support. Because oftentimes, and it's very unfortunate, I will treat the patient, and then as the patient is getting better or worse, I start treating the support, right? So as much as we're trying to do our best, we're improving access, we're improving the type of medication, and patients are getting psychosocial support, but there's a gap, and I've seen how to fix it. It's good to attend these things. We talk to each other and we learn a lot of things. So the CHPs, and we know CHPs and UHC is such a buzzword in the country right now. And there's a what's this called? We worked on a curriculum for the CHPs training, and it has mental health action points, and it has part of the curriculum. So they're already trained. So this just now goes for anyone, whichever county. They're trained, there's a curriculum, and they're accessible to the community point. So it's important to treat the patient, yes, but it's also important to prevent a future patient. So thank you.
Thank you so much, Daktari, and truly, as you were speaking, I was able to pick the idea of engaging really the community, because everything happens at the community level. And again, I was looking at some data for some caregivers who are randomly, someone just randomly administered a depression assessment tool on some caregivers. And most of them had very high scores for depression, and they never even knew that they could be experiencing depression. Yeah, so it's important for us to keep having that conversation about engaging both at the community level, what are the issues at the facility level, so that again we don't keep having people coming all the way to you, the psychiatrist, and then the ones that were taking care of them are on the queue. We are joined by Caleb, and I'll allow him to introduce himself and tell us what he does and where he does it.
Thank you so much. My humble apologies for being a little bit late. I was informed this had started and had to rush upstairs. My name is Caleb Kiarie. I'm the Director of Government Relations for Shamiri Institute. It's a great pleasure to be here. Shamiri Institute, for those who may not know, is a mental health organization. We deal with adolescent mental health in secondary schools. We provide what we call as low-touch therapy and interventions to secondary school students across the country. We are approaching 100,000 students this year. Our model is usually we have a 3-tier model. Maybe try to simplify how we do that, is that we will go down to secondary schools. We recruit regionally, locally. So let's say we're in Kiambu or Migori or Kakamega, we will recruit youths from within the community between age 18 to 22. Usually just to act as our lay providers. We will take them through some stringent training, or so to speak, so that they can allow us to do the implementation of our program in the schools. It helps us cut through the fat of some of the tensions that students go through in terms of having maybe someone who's my age or slightly older speaking to them, create some of that attachment that they can be able to have. We do that across as many schools as possible. We do this usually term 1, term 2, so that we do not impede with the examinations. It's been proven to be quite effective for us because the students actually are very receptive. It's an employment opportunity also for various students, but also it is cultural context to it. When we recruit locally, we're able to have children who not only look like the students they are going to be dealing with, they speak the same language, any cultural contextualizations you want to take into consideration, they're able to cover. And then the tiered model is that we'll have those students, those youths, do the implementation, but also they're hovered over by our clinical supervisors. And then above that, we have our clinical experts so that we can be able to cascade any situations we catch where students have any essential needs. We catch anyone, we scan for depression, anxiety, and any other symptoms that might need excessive care. We're able to cascade it up the ladder, and that's what we do. It's a very elaborate program, but that's my best way of shortening what we do. Thank you so much.
Great. Thank you so much, and welcome to the panel. And maybe as we continue, I would want you to share with us, because you've brought in the aspect of the lay providers for mental health, and what are some of the systems you've put in place in terms of supporting these lay providers? I'm assuming that they are also students. Yeah, so what support systems have you put in place?
So first and foremost, we definitely make sure, because we have a very robust therapy ecosystem. We have a lot of psychologists who work in our organization as well as psychiatrists. We are very cognizant about the issue of debriefing, as you've actually mentioned, and that usually is a concern of ours. And we also want to take into consideration issues of vicarious trauma, which actually does occur when we do run into a student or students who actually have very severe issues. We actually make sure that all of our fellows, as we refer to them, are taken through debriefing after every single session that they do. And we just have to cascade that as often as possible to make sure we take care of them. I'm reminded of the story we all heard downstairs of Philomena. And vicarious trauma is a real thing. You can imagine if you're someone who's never had to deal with that level of trauma before, and you're having to encounter it and deal with it, it's a real thing, and it's happening very much so in the therapeutic world. Dealing with people who are going through excessive amounts of trauma, and you're a therapist who's having to be exposed to this consistently. Vicarious trauma becomes a real thing, and that's something we are taking into consideration. So we make sure debriefs are happening as often as possible with our people. We do not want people who are already traumatized or already impacted negatively conducting mental health interventions. It's shooting ourselves in the foot, essentially.
Thank you so much, and I think we are all agreeing that it's very, very important that we put in structures and systems to support people who are taking care of others, because we always say that if you're destroyed, then you will keep destroying others. So self-care and always ensuring that the person who is taking care of others is well. So we are coming towards the end of this session, and I would want us to ask the panelists some questions. So this is an opportunity for us to ask questions to the panel, if there's anything that would want them to clarify based on their experiences and expertise.
Thank you so much. I'm Joel Omio. I appreciate the fact, Kennedy, the mental health focal person for Changamwe, you've mentioned integrating CHPs to the system. It is a great, great initiative, but my worry is Madam has talked, I can't remember your name, can you please? Mombi. Mombi has talked on the curriculum and probably you're going to train CHPs. I mean, the curriculum has an aspect of mental health. So the CHPs are going to be trained on mental health. My worry is what kind of support would probably the CHPs give people who need, who have mental health challenges? Because we need to define this kind of support. I might understand it quite different. And kushuka chini, there is this aspect of IPGT. Yeah, and I understand now if the CHVs have been trained on mental health and are giving support, they would be able to identify people with the same mental health challenges in the community. So I'm just thinking out loud, can IPTG work at the community level? Yeah, because now IPTG will support people with probably, relatable or probably specific mental health challenges. So I'm just thinking about loud. So yeah.
Okay, thank you, the panelists, for that insightful presentation. I'm Ken Okoth from Homa Bay County. Yeah, I just wanted to get maybe a slight basic information on how we should undertake basic psychological debrief to our healthcare workers, because many times they really go under a lot of issues, most of the pressures from work, family, and expectation from the population, and also maybe some traumatizing events within the health facility. So precisely, how can we undertake psychosocial briefing, debrief onto this? Because many times we always undertake PFA, which I think is not very much impactful. Thank you.
Good afternoon. Thank you so much, our panelists, for that presentation. I just wanted to know, as a caregiver, what are the indicators that now I need some debriefing? Or are there symptoms that would direct that person or even your fellow friends, so that you can say, this person, I think they need some debriefing, or you yourself, what is this that would cause you to begin to seek for that help?
Thank you so much. I think we'll allow them to respond to those, and then we'll come to a second round. So I'll ask Dr. Mombi to talk about the psychological first aid support. Jane Thiomi, you'll talk about the indicators for the caregivers, and Ken, yours was directly to you. You can talk about the IPTG. Thank you.
Okay, so I'll answer it as I've understood the question, and then you can clarify. Why there has been widespread, the first level of intervention was MPHSS and PFA, and that has been done quite extensively by Ministry of Health. The reason why that was done, and it was training, right? Everyone was a candidate to learn about PFA, because it was the lowest lying fruit to the greatest number of people, right? After which, once you're able to identify that this person has a challenge, an issue that requires more support, then you enter them into the referral system. So, us training PFA was not a way of giving poor medicine to poor people. No, it was the first line treatment. And we all know once you've done the first line, then you're able to assess and you go to the second line, right? So the second line of treatment, even debriefing on its own, it's a course you're taught. It's not, okay, let me just tell you 2-3 things and then now you can no, you'll cause more harm than good, right? So debriefing it's a skilled intervention. And that's why even the CHPs, the curriculum had to be modified to now include mental health modules. And even then, they're taught how to recognize. And once you recognize, you refer, right? So it's not, please do not leave here saying something about mental health was mentioned, now I'm a pro. Please, you will do more harm than good, right? It's a skilled practice. So once, if I'm able to teach you PFA, I'll teach you in, well, not in 1 hour, but I can teach you that one quickly. But what that helps you is to identify there is a challenge. Meaning, I spoke to Dr. Mumbi, I got Dr. Mumbi's number, or I got this sub-county, I got Changamwe, I now have his contact, he can tell me where to go for the clinic. So now you've entered the referral system. And you see now once more people do the PFA, they all get access to the referral system. So you can come from school, from church, from sports, you're coming from Mind Skills, you come from the Youth Summit, all these are access points to the existing referral health services. I hope I've answered the question.
Thank you so much. You have. Ken, go ahead.
Okay, thank you. Responding to Joel's question in regard to IPTG, I will respond this way. In Mombasa County, in partnership with the Strong Minds, Uganda, as a county, we came to realize that mental health actually is rampant in Mombasa. And you find that really people are undergoing a lot of issues. And after discovering this, the county, together with the Strong Minds, partnered. Because the Strong Minds have this program in several countries in Africa. And after reviewing the module, we found that it's beneficial to our people. And so we are now to partner with them to come down to Mombasa and train our people. That is the CHPs. It's a therapy. Actually, it's a model that is very good, and it's very simple. And its intention is to be used in the community, whereby the CHPs are taken through the sessions for 5 days. They were trained for 5 days. But now, after the training, assessed what they are doing in the community. And what we need to understand here is that IPTG, specifically, it's for treatment of depression. Not more than that. Not other mental illnesses. It's specifically for depression, whereby now these CHPs are taught, or rather they are shown how to identify these issues in the community, and using the PHQ-9, categorize if it's a mild, moderate, or severe. But now for their case, they cannot treat severe cases, so they refer. So the moment they identify this client, they refer to the nearest health facilities. And there is a very clear referral system, whereby now at the sub-county level, we have the coordinators in all the sub-counties. And you find that in each and every facility, we have also the focal person who are well trained about mental health. So from the community, that indeed this is a model that we've seen work very well in the community. I had a privilege of actually attending one of the sessions, or several of the sessions, done by the CHPs. And actually, the kind of testimony that you are getting from the community, it's really, really encouraging. So this is something that is practical. It's something that can be done at that level. But the issues that they cannot handle, and I insist, they do refer them to psychologists or link them to the facility so that they can be helped. Thank you.
Okay, so we are talking of caregivers at two different levels. We have the caregiver who is one like us here, who is seated here, and we have the caregiver who has a patient at home. In the African context, if I have a sick person, for instance, if my husband gets sick, I'm expected to take care of them by the society, regardless of whether we are in good relationship or not. So you just land on that job. So many times, people are taking care of the sick people, but they are coming from a point of brokenness. They are unhappy with this person, and yet they have been stuck with this person to take care of. So when we are talking of caring for this carer, it begins from the beginning. It's from the beginning, because you know you are the wife, or you are the husband, or you are the child. You are supposed to take care. You have no skills to begin with. The more you are less informed, the harder it becomes, and more to that, you are a candidate to burn out very quickly because you don't know. So the first thing, and what happens in our facilities, even when somebody is sick, we don't give enough sufficient information to the carer to be able to take care of the person who is sick. So already that begins a process of brokenness for this person, and they become candidates for burnout or for whatever outcome of stress that would have. So the first thing is to mitigate against that. So giving proper information as much as possible, as accurate, and in a way that is understood by the patient's carer. The caregiver understands. We give it in the language that they understand. So that is the first one. If then they are giving this care and they feel isolated and they feel helpless, they are unhappy, they don't know what to do, at that point, then they'll need to be taken care of. Whether they'll be in a debrief session or whether they will go for a one-to-one session where they can be helped as individuals, or whether we can have debrief. The same for the healthcare workers. Working with healthcare workers, what you realize is that they're coming from the same communities we come from. Some of them are going through issues. Some of them are going through GBV. Let me say GBV because that's the one I get very often because I'm interested. Somebody is going through GBV. They were beaten last night, but they are supposed to give proper care to the patient that they fight today. They are living in this same country where we are all struggling to make ends meet. So they are affected by every issue that affects us, and yet they are supposed to be very good to the person who comes. So then, to mitigate that, we need to mitigate before we wait for for them to have indicators for us to come and take care of them. We need to mitigate that, before. We need to isolate, to get places which are safe spaces, get safe people they can talk to, let people know they can do it. I like what Dr. Mary does in Kisii. They have Zuba, they go there and dance. You dance all your stress out every Tuesday and Thursday. They just go and dance and dance and dance and dance. And stress has a way of making, escaping your body when you do some things. So we do we build systems which mitigate burnout even way before that burnout happens. Because when it happens, when they get into those serious things, then it becomes harder to come out. And it becomes expensive because it takes time away from the caregiving which they're supposed to do. So I think we need to have strategies. We need to have institutions that recognize trauma and the trauma plays in the carer's life, and then we mitigate that way in advance, particularly in the organizations. At home, let us train people. Let's train caregivers. Let's tell them exactly what they are supposed to do. That way, we reduce the chances of them having burnout.
Thank you so much, Jane. In the interest of time, we'll do just 3 last questions.
Yeah, thank you very much. This is very informative. I came here deliberately because, number one, I was a carer for my mother. So I think it spoke to some experience that I've had. And fortunately, the doctor who was managing my mother was giving me information, every single bit. So that really helped. But also, I work in the OVC program, where I am working with caregivers who sometimes give up on their children, give up on their spouses, give up on themselves, and they stop even caring for the children or the people that they are in their hands. So what I wanted, maybe some help from Magina Bon. I'm doing badly. Yes, Jen, please forgive me for that. Do we have a package that gives clear guidelines on providers? Like now, in my case, our program is able to take the caregivers through the skills building, maybe giving the information. So do we have those guidelines in place that really clearly stipulates on what is the package that should be given to the carer? So that with those guidelines, then we know where now to bridge the gap. Because as it is right now, I don't think we have much information, especially when it comes to mental health. Perhaps in HIV care there is. But now when it comes to other part of mental health, I wouldn't even know where to start. Maybe starting from my experience is what I would use, which is not enough, I must say. So maybe you could speak to that. And if there is some guideline somewhere, how do we access that? Yeah, thank you.
Okay, thank you. My question, the lady at the corner asked almost the same question. I don't know if it was answered, but for a counseling psychologist and all the psychology part, and this is okay, Magina, we have the same problem. Kennedy, sorry. Now, for men, we have to be aware, we have to acknowledge that the issue of stigma ya kwamba wanaume you're the strong ones in the society, it remains whether you're a psychologist, a counseling psychologist or not. So in as much as we get the awareness that through this you can talk, you know it's okay not to be okay, it happens. But then you realize when you gain experience in this field, kuna venye unapanda juu. At some point you get to a point where even seeking that help is a problem, because people know that you're strong, and then the ubabedume, it still tells you that, guy, you're strong. Now, for generally to all of us, at what particular point, and what are the pointers that you need to see by yourself, not really being told, but for creating awareness for us as caregivers? At what particular point are you supposed to go and look for this help?
All right, thank you. So I don't know who this question will be directed to, so members of the panel, please feel free to answer this question. So one thing I've kept hearing over and over again today is, when you get a case that you cannot handle, refer. When you get something you cannot handle, refer. That's a word that has been thrown around this whole time, right? But my concern then is there like a standardized and like beyond the training that psychologists we get like in our university, or even beyond university, like the trainings that we get, is there any standardized practice for this is how you handle such a case that is widespread, and it's not just accessible to just trained psychologists, but like even the guys that don't have a background in the same, do those guys have access to knowing that when you're referring this case, by the way, you don't say this person's name, or you don't, do they have training on how to stick to ethical guidelines and how to handle referrals? Is there a standardized referral practice that is widely known by people who don't even have a background in psychology? Because that might be the next problem, because you might have now like a case overload of guys have gotten cases, they have referred, but guys are not getting the help that they need. So is there a standardized referral practice that is for everyone?
Thank you so much. I think we'll take the responses, and I'll request the panelists to summarize because we are running short of time.
Okay. Responding to Evan's question, and also the lady at the corner over there, I think it's related. So you find that as caregivers, there are things that can point to that situation that things are not okay with yourself. And we need to discover ourselves. The moment you realize that maybe probably the things that you used to like most, you don't no longer have the interest, that's one of the pointers that things are not okay. The other thing is the way you handle people, the way you respond to questions, and especially the healthcare workers. I don't know if you have gotten to that point when you answer the client, then when you go back and think about it, you realize, then you ask yourself, and why have I answered like that? So then the other thing is that insomnia or lack of sleep. You find that this can be some of the pointers that things are not okay, loss of appetite, and also how you relate with other people, and especially the people who are around you, including the family members. So that can really show you that things are not okay. So when you find these things, it's good that you go for a debrief session, or rather self-care. You can have a self-care, and in that way, you get energized. Also something else, you find that the energy levels goes down. When things are not moving on the right direction, the energy levels goes down. I summarize with that. Thank you.
Okay, there was a question that was asked directly to me, whether there is a self-care package for caregivers, especially the OVC caregivers. Maybe I will have to check if one exists. But if it doesn't exist, we are all here. We can make a package. But some of the interventions that work, especially for the OVC, and people who have taken care of patients for a long time, is building their social capital by bringing them to support groups. Because in support groups, you get friendships. Friendship is one of the greatest medicine that you can have. Unfortunately, the poorer you are, the fewer friends you have. So I think, just bringing people to support group, then they do pleasurable activities within the support groups without being judged. We are such adults that everyone judges you, that whatever unafanya ni utoto au si utoto. They come to that support group and they just be. You cry if you have to, and then you have support. And then you build dreams together. When you're looking at this child, when the child was born, what was that thing? Because you were happy at that moment. Who did you see at that point? If things were different, what would you do if this child was not maybe HIV positive today? Because HIV positive is not a death sentence. People grow up to old age. So you start building their, sort of that desire, you re-energize them, but you may not be able to do it as an individual. But if they're within a group, they can do that through drama, they can do that through music, they can do many things together if you bring them together. And particularly, that social support just does the magic. There was a referral question.
This is the referral question that came from Mini. Well, I'm not the expert here. I probably will defer to my colleagues or maybe even Dr. Mombi on this one. We'll say for the lay person who is becoming more and more cognizant of the importance of mental health care, there's a huge gap that we have to fill. So already in the mental health care space, as again, I'm not an expert, but I'm somebody who's involved in the space more so in the government side, we find ourselves having to bridge gaps of translation in terms of this ecosystem, in terms of getting people more accustomed to what kind of package could be available, what kind of lay person's understanding of mental health care that they can provide, as was explained over here by Jane, for the person who's taking care of their loved one at home. We have multiple wives and husbands taking care of people with dialysis, with maybe, or even doing hospice care because maybe they can't afford getting someone to do it for them. There's a lot of, like we said, vicarious trauma and a lot of weight on their shoulders. I would imagine it is extremely essential for our space to come up with some kind of solution for that. Again, I think, Dr. Mombi, maybe don't feel pressure if I throw that at you for a much more specified answer to that.
Okay, so MOH launched some self-care guidelines, if I'm not wrong, last year. So there are guidelines. They're not specific to caregivers. They're just self-care guidelines. Like we have mental health at the workplace. So these guidelines available, Ministry of Health website. Second question is, I can only speak for medical doctors because ethics is taught. So we have a very clear-cut referral system up and down. But with the counseling psychologist council coming up, I'm guessing that in their action plan, those ethics at different levels of training will also be solidified to ours. So I think there's some progress in that direction. Now, 3 people have asked about what to look out for, and my colleagues have mentioned them. I think you just need to simplify it. Mental illness is illness. What does that mean? How does illness present? It'll affect you physically, it'll affect you emotionally, it'll affect you psychologically, right? So if you're being affected in 3 modules, in any of these 3, let's just make it as simple, 3 + 1, right? Your emotions, your psychology, your physical. If you're getting 3 symptoms in any of these plus 1 in another, go for help, right? You will never come to a mental health practitioner and say, I felt this, and then they say, you've wasted my time. Come and let us tell you, by the way, you're fine, right? Come and get a good report and go home with a good report, right? So don't look for people always say, Miss Yombaya kama huyo, right? No. Why do we want to be so bad that we get help at that time? Say, why suffer, right? Us mental health practitioners don't like suffering. So 3 + 1. If you're not sleeping, your appetite has changed, your energy level has changed, and you're always sad, come, right? If you keep arguing, you're so happy, or you're on holidays, or your children are on holidays, and this time you have fought with everyone, even the chicken, no, Mama has come home. You come and tell us, by the way, no one is talking to me. And you'll find that maybe they are not talking to you, it is you not talking to them. See? So come. Have a very low threshold. You know the way we say there's something called man flu, right? You have man flu for your mental health. You feel a bit unwell, 3 days, come. We have never said, by the way, this one comes too much. Because every time you come, we will psychoeducate you, right? And once you have heard the same 3 things from Dr. Mumbi, you'll now go and start rumors about what I told you. Are they rumors anymore? See, it's facts. Bas. So we are now increasing our critical awareness. So come, 3 + 1, we've agreed. If nothing else, just remember, your health is mental, psychological, physical, emotional. 3 + 1, that's it. That's the threshold. Sawa? Good.
Thank you so much. Thank you so much. A lot of applause for our panelists. I think that was amazing, and we can all see the passion. And I think for me, there are 4 things that we have to take away. Social support for caregivers, very important at all levels, family, community, facility. Then open communication between caregivers and providers so that someone doesn't feel like there's something I am not being told, there's something and I don't know. Then we spoke about the issue of packages for caregivers. What is that? How does it look like? And probably what needs to go into that. And then I like the 3 + 1, man flu. Don't say, I am not as bad as so-and-so. Seek help. So I want us to end this session. Thank you so much, our panelists. Let's give them another clap. That was really amazing. We wish we had more time, would have continued with this, but again, time is not on our side. We are going to quickly move on into the next session, which is integration of mental health. And we'll have our panelists coming forward, Michael Gaido, Dr. Njuguna, Ken. Kindly move forward. Please don't leave. We are doing the next 20 minutes. So please don't leave. Let's give audience to these panelists. So we are going to be discussing integration of mental health. As we are aware, we are strained in terms of human resource. We are strained in terms of the mental health service providers as a country, but there's something that we can do. And one of the guidance in the Kenya Mental Health Policy and the Kenya Mental Health Action Plan is integration of services. So that again, we are able to see how do we offer more than one service within the same space or within the same provider, and that service includes mental health, because we've seen the way mental health issues are affecting everybody across all the service provision points. And data has shown us that about 25% of the clients who go into a facility have a mental health condition. 45% of those who are in inpatient have a mental health condition. So again, integration is critical for us. In front of us this afternoon, we have 3 great specialists. We have 1 lady and 2 gentlemen. And they'll be speaking to us what is their perspective and what are their experiences in terms of integration of mental health, and I'll allow them to introduce themselves. I'll start from this end.
Good afternoon. My names are Michael Gaido. I work for LVCT USAID Stawisha Pwani project based in Mombasa. I'm a GBV expert and focal for mental health in the coastal region.
Good evening. I'm Dr. Mary Njuguna. I'm a consultant psychiatrist in Kisii County, and I'm also the county mental health focal person in the county.
Good evening. I'm Ken Okoth from Homa Bay County. I'm the Director of Nursing Services and also coordinating mental health and psychosocial support for the county. Also, I'm a total orphan.
Thank you so much, our panelists. So we are going to start off with some questions that we are going to ask them, and after that we will have you also ask your questions. And my first question is going to go to Michael Gaido. You spoke about your work in the coast region. And maybe you can share with us what is integration about. When you talk about integration, what is it about and how does it look like in your setting?
Thank you. First of all, integration, many a times when discussed in this kind of spaces, seems to be like a very big word. Many things we do within the spaces where we work, we actually integrate services, not knowing until it is defined. But actually making sure that services are not siloed, services are not offered in one corner and another corner, whereas they can be intertwined, overlapped, or piggybacked on other services. I'm just using very basic words that we can understand, that I may be offering a GBV service and not forget I can also offer mental health service. I may be positioned to offer a service at the community level, a service that maybe is offered by a community health promoter within a household, maybe looking for cases of diarrhea and so forth, but not forget to to look for mental health and refer. That HTS provider who gives services out there because somebody has come to test, and by the fact that they are being tested, then they could be having other reasons to be checked for mental health. That person who comes for, who's been enrolled maybe in care because they are HIV positive. It's not only about dishing out that medication, there could be other things that can be done together. So for me, integration goes beyond just dealing with a siloed kind of way, siloed mentality, looking at a service and clearing you. And it goes beyond service, it goes beyond a program that I'm doing, goes beyond many other big things.
Thank you so much, Michael, for really elaborating on that. My next question will go to Ken. And maybe, Ken, you can share with us, what are some of the anticipated challenges, and especially when it comes to integration of mental health services within the other services?
Okay, thank you for that question. And first, I have to acknowledge that there's a lot of challenges which has been there in terms of mental health implementation in this country, because maybe initially, before COVID pandemic, mental health could have been said as one of the neglected conditions which we were dealing with as a nation. But after the COVID pandemic, it has been realized that it is one of the key conditions which we have to undertake it with. So one key challenge which we have is the issue of human resource, and also this goes into maybe the issue of stigmatization by even our own healthcare workers, because apart from the community stigmatizing mental health issues, even healthcare providers really feel that they should not be part and parcel of mental health care. You find that you can get even scholarship for mental health trainings, but you might easily miss persons to go for this. And we are really trying to advocate for healthcare providers that as much as you go for mental health care, it does not mean what they believe that after that you will behave like the patients. The way you see us, do we look like mental patients? Okay, then the other challenge which we also have is still in terms of resources, is the issues to do with infrastructure in most of the counties, and more specifically I'll talk about my county, whereby there was a time when we were still in national government. It was gazetted that all the district hospitals should be having at least a mental health ward. Medical ward should be part and parcel of the psychiatric ward, just to stabilize these patients. But you find that most of the managers, even due to stigma or lack of the resources, these spaces were not availed. And if they were availed, you will find that they are availing very, very pathetic rooms or very, very bad infrastructure for mental health cases. or at a given point you might find them being put in a periphery. Like I think in my county, Homa Bay County, for those who have been there, there was a time I was pushing for a mental health unit, and I was being pushed by one of the ministers, the former minister, to take it to almost a facility next to an island, Lakeshore, that is Kisegi for those who have been there. And it was renovated, but at the end of it, the beauty of it, that the roads to those places could not work, and it didn't happen. Then the current governor also came in. We wanted to relocate to a facility close to her home. It's a big facility, but it has got low workload. She also refused that. Why do you want to bring these mental cases close to my home? But the beauty of it now that the Homa Bay County referral was gazetted to be level 5, now it has to have a mental health unit within it. So that one has also saved us a bit. The other challenge which we have also had is the issue of advocacy, low advocacy, or advocacy of mental health, because very many of healthcare providers didn't like talking about mental illnesses. So it reached a point that we, as the champions of mental health, we had to sensitize the stakeholders, starting with the governance issue, maybe the county assembly, CHMTs, and the sub-county managers, so that they should know that mental health is just like any other condition, and it should be given a priority. And in this line, we really advocated for it to be, most of the issues of mental health to be put in annual work plans, and also into the CIDPs, that is county integrated development plan, which do occur 5 years plan for. It's like a manifesto for the governor. So this advocacy thing, we've really brought it in, and it has really tried to alleviate some of the challenges which we have in terms of mental health. The other challenge which I think we have just discussed here is the issue of wellness of caregivers, that's the healthcare workers, because we find that at the moment most of the healthcare workers really have a lot of issues, starting from their family, environment, working areas, they are understaffed, the burnouts, all those things. So we have really advocated that we should try to do the debriefing sessions as PFAs to these healthcare workers, and also to have wellness clinics, so that when we have a caregiver, that's a healthcare provider, having some issues, because some of these issues push them even to be with issues of alcoholism, and alcoholism is part and parcel of mental health challenge. And with the HR officers, they will always see this one as a disciplinary issue, not a health issue. So we've really also advocated, we have also brought in the healthcare, in the HR, human resource department, to know that these persons who have issues to do with substance abuse, alcoholism, those healthcare providers who inject themselves with diazepam, ketamine, at a given point, these are patients, and they should not be taken through the disciplinary processes by stopping their salaries or transferring them. But what we've agreed is that we screen these members, these workers, then we refer them appropriately. By referring appropriately, we refer them to, we have some rehabilitation centers which we have an MOU with. So we refer these healthcare workers and link them to these rehabilitation centers. And what we do, we attach their salaries, because the NHIF pay around 25% of the cost. The 75% we attach the salary of this officer. Then it is staggered, so that we also look into a third rule. And the only thing we do that we get the arrival letter is like when the patient when the officers arrived in the rehabilitation center and he has been admitted, that is what will help him now not to stop any issues of disciplinary. Otherwise, we really have a lot of challenges, but the other issues also, we have few stakeholders or partners supporting mental health issues, and we have to go through the integration way now. And that's why we have most partners now who have been supporting HIV, NCDs, and SGBV. coming into this space and we're working together. And the last one, which I think has also worked well and most in my place, Homa Bay County, is the issue of this integrating sexual gender-based violence, HIV, and NCDs into one space. And most of we have our clinics, now we have at least around 4 clinics which are fully functional under this with a Christian name as Hope Center, so that the stigma is not there. When a class goes there, is know that it is for Hope. She could be a patient with TB, HIV, gender-based violence, mental health, but it won't come out significantly that it was mental health issue. So I think most of the challenges we are trying to undertake to above board, but they're still heavy on us. Thank you.
Thank you so much, Ken. Really quite a number of issues there, very pertinent issues that we need to look at. How do we address them as we continue integration? And I want to invite Dr. Njuguna, and Dr. Njuguna as a health manager in the county. What are some of the benefits that you have seen or you anticipate in terms of integration of mental health into the other services?
That's a very nice question you had asked. I had prepared to present something like that if we had more time. Let me start first of all by wrapping up what we are saying and what Gaitho had said in terms of mental health. And when you're trying to integrate mental health into other aspect of healthcare, what WHO usually says, or the mantra that they've put up across the world, and even now that we are celebrating or we are marking Mental Health Awareness Month, is that we need to remember there is no health without mental health. So every other health aspect has mental health within it. And so the fruits or the benefits of integrating is that, for example, if you're talking about a cancer patient, and if you ensure that they are accessing mental health, or they are able, the people who are giving the cancer services are aware of their mental well-being, then that person gets wholesome care. And I even give this story a lot of times when you're thinking about integrating mental health in HIV. You'll find that sometimes the people who treat HIV or in the CCCs, they keep hitting deadlocks or dead ends with a person who's been treated for HIV, has been given antiretrovirals, has been given adherence counseling, has been given peer support, and there's somebody even who works with them from the village to to the clinic. They have been given incentives to come to the clinic, but you still find that they're not taking their medication. They look like they have lost hope. They look, and you're like, but we have tried to provide everything. And then most likely it's because someone has not identified that they're having a mental health issue. They're probably having depression. And if we had identified this depression earlier on, or even at the point when it started arising, then it would have been easier. You just treat the depression as you treat the HIV, and the person gets comprehensive care, and they get a better quality of life. We've seen that when you have mental health issues, it reduces the quality of life of that person, irrespective of how much you will treat everything else, or how much you will give for everything else. If you're not treating the mental health aspect of this person, then you're reducing the quality of life of that person. So when you integrate mental health with cancer services, if you integrate mental health with GBV, integrate mental health with HIV, then these people get treated silent. The other problem with mental illnesses is that they are silent. In as much as my brother here was saying that many people stigmatize mental illnesses because of the florid things that we see in the streets, the quote madmen that we see in the villages or in the markets, and we even came up with a saying that there's no market that does not have a madman. So again, by destigmatizing mental illness and mental health issues, we are trying to get rid of that name madness. It's not that they are mad; they are ill. That person is sick just like anybody else who is sick. So many people stigmatize mental illnesses because of the florid nature of mental illness. But what we don't realize is that it's actually a silent illness. Like depression, anxiety, things like eating disorders. There are so many disorders that we can list that people wouldn't see, when they look at you, they wouldn't see that you're having a problem. But internally, someone is suffering with those problems. So the problem is that they are silent, and so we need to look out for them. We need to look out for them, for people who are coming for the outpatient services. As you correctly said, there's a high percentage of people who are coming to the hospital to be treated for malaria, to be treated for a foot problem, but 25% of them have a mental illness. So we need to look out for them. And so the benefits of integrating is that we are able to catch these mental illnesses earlier, and we are able to give these people a better quality of life.
Thank you so much. I wish we had more time because we would have really continued. I'll ask Michael to add something, and if anyone has a question, we can listen to it so that we wind up and join the rest of the team downstairs.
Yeah, just to add a bit on the benefits, and noting that when it comes to mental health issues and other illnesses, and a good example she cited HIV. We know these two conditions share similar determinants. In that case, same determinants of acquiring HIV would also be similar determinants of acquiring mental illnesses, whether it is in terms of age, the livelihoods and so forth. Then what does that mean? Then when these two conditions occur, for example, HIV and mental illness, we realize that then we will be able to see impacts that are not so good within our society. And so therefore, calling for integration of screening, service delivery, and so forth. Some of the benefits, just to add on to what she has said, you realize if we integrate mental health into many other services that we offer, we will be able to cut on so many costs. Is that so? One, of employing resources, I mean staff to do such kinds separately in siloed ways. Two, we'll be able to reduce those missed opportunities, because the moment I'm taking care of one element of an illness or a service, then I may not be able to miss on screening for mental health issues. And so therefore, we will be able to cut on missed opportunities. The other thing that we know is about the deaths, the morbidities, the outcomes. We are likely to reduce on the disease outcomes, or rather improve the disease outcomes, improve on the livelihoods, improve on the lives of people. And so therefore we'll cut down on morbidities, we'll cut down on mortalities if we strengthen integration within the spaces where we work. Thank you.
Thank you so much. I will allow one question in the interest of time.
Hello. Mine is not a question. Mine is just a comment about integrating services. In Kiambu County, we have seen a decrease in the number of school expulsions because I think over 80% of high school students who are suspended need to go back with a note, a report from the psychologist, and NAT has picked up quite a number. So that's a referral path, and NAT has integrated the disciplinary services of adolescents and mental health services. So that's a successful story from us guys, and I think most counties are doing that as well.
Okay, thank you so much. My name is Ruth. I just wanted to ask in relation to what Dr. Ria said, how you are integrating all these services with the students at school before they reach that point of them being referred to the hospital because they are suffering some mental illness. Thank you.
One more question, a burning one.
Okay, thank you so much for the opportunity. My name is Judy. I'm happy of what is happening in Ikisi County. I wish it could be done in all the counties where mental illness has been integrated with other services. I know it's not easy to screen clients for depression or anxiety. Somebody needs to have time and the passion to do it. I've done it myself, so I understand. It's not a matter of asking a client, how are you today? And I've come to realize, apart from level 4 and 5 facilities, we do not have mental health expertise in health centers and dispensaries. Clients are being referred. If you don't have transport, you go home with your depression, with your anxiety, with your stress, with your suicide ideation. Nobody is attending to them in these other facilities. What are we doing to ensure that other partners or other county governments are integrating these mental health services in all facilities? When I go to a health center and say I've not been sleeping, I've not been eating, you don't give me multivitamin, you don't give me sleeping pill. Somebody is able to pick this person is having depressive symptom. What are we going to do? I know it's not happening in these other facilities. We need to do it as soon as possible.
Thank you so much. Final one.
Yeah. Good evening, everyone. My name is Nancy from Kenyatta University. We are here, the three of us, with Evans, Ruth, and Faith. Very fast, my question is on, I'm actually thinking aloud in terms of spirituality. How do we integrate spirituality when it comes to psychological interventions? Because there's a lot of myths or beliefs that are associated, especially with psychotic disorders. When you look at the symptoms for persons who have schizophrenia, and then you go back to the spiritual aspect, there's a lot of, with the spiritual lens, people will perhaps refer that as maybe being is a curse, or maybe they're demons or something like that. So how best can we integrate that? Yeah, thank you.
Thank you so much. I think we will wind up now, and I'll ask the panelists to respond. Michael will talk about the schools issue. Dr. Njuguna will respond to the issue on the Kisii, and then you can pick up the religion. And as you do that, you can also give your parting shot so that we wind up.
Thank you. For schools, it's a good space to integrate mental health issues. As of today, spaces where we work, for example, I mentioned I work in a coastal region, working in 4 counties. To date, in the last 6 months, we've reached 45 schools, more than 2,000 students, with mental health campaigns, including Mombasa, which they also started, and we are working closely with them, together with Kwale, Taveta, and Kilifi. And so therefore, we work through the school health programs just to, we hope, piggyback into the activities to push that agenda of mental health. And so therefore, as a parting shot, just let us know that we shouldn't leave any young person, adolescent behind. Let's broaden the lens of looking at even all the subpopulations within the adolescent persons, whether they are adolescent women, adolescent people living with disability, whether they are those adolescent boys and young men, and we know the challenges that they go through, including alcoholism, lack of employment, and many things that we may need to look at and how they impact on their mental health. But most importantly, meaningfully and responsively engaging them, making sure that we bring them on the table, put them in the policy spaces, put them out there to engage through the digital spaces. And we know there are many other areas that we can integrate in the community and at the facility. Thank you.
Thank you very much. One of the ways that we have tried also to get into the school spaces in Kisii, even before I go to answer how we're going down to the sub-counties, is having something we call technical working group at the county level. A technical working group that is not only constituted of healthcare personnel. It's a technical working group that involves the education office in that team. It includes the children's services in that team. It includes the pastors in that team, in the technical working group, so that if we're meeting quarterly, we are asking ourselves, what are the mental health issues that are affecting this community, and how can we tackle them from the different spokes? As we said, we cannot handle mental health in silos or in a silo. It's not a standalone thing. Mental health infiltrates every aspect of a human being's life. So a technical working group for us in the county has helped us even for them to be aware that we are concerned about their mental well-being, and the police can be calling us, as you heard from Kiambu, that they know that we have mental health interventions that we can do, and they can call you for awareness. The schools are calling us for awareness, and so on. So we are able to get into that. Then what has worked for us in Kisii County in trying to get mental health services to the far to reach areas is what is it called? Unpackaging or spreading out the mental health expertise that we have, in as much as we are very few. In Kisii County, we are only 2 psychiatrists in the government and only 2 psychologists in the government. But we make sure that we work with others who are in the NGO world. We work with LVCT, and LVCT has helped us in training. So we train the healthcare workers, we train the nurses, we train the clinical officers who are at the health centers. We train those ones who are at the sub-county, so that when they see someone who's talking about sadness, someone who's not having sleep, they get a kind of a high index of suspicion. They're like, oh, I had a training, and this lack of sleep, lack of appetite could be anxiety or depression. And then the other thing that we've added into the training is that we came up with a mental health directory, so that each sub-county hospital has a mental health directory. So that if you're feeling like this is a mental health issue and I don't know how I should handle it, you can call someone. We are at least lucky in Kisii County. We also have clinical officers that are trained. Some of them are in the sub-counties, at least 2 sub-counties. But the other sub-counties that don't have trained clinical officers in mental health, we've appointed a sub-county mental health focal person. Even if it's not someone who's trained particularly in mental health. There's a sub-county mental health focal person in each sub-county who now coordinates together with my office, and they can ask questions and they can do their best to treat that patient if they are a clinical officer, because they're trained to treat most cases. And even if it's a nurse, they're able to manage a case at least down there in the health center. And if they're not able to manage it, then the directory helps them to call me or to call somebody else, and they can refer the patient to another facility. So having focal persons and having a directory really helps. And again, training as much as you can be able. And you heard that even the CHPs, there's curriculum for training even the CHPs. If you can train those people that are on the ground, it will be very helpful to actually get the mental health services closer to the people who are very far away. And maybe my parting shot is that in this mental health awareness month, and even going forwards, we need to move more for mental health, and especially in terms of investment. In as much as we are here with the donors and we are saying that we are happy that they are supporting us and they are giving this, what is it called? They're giving resources here and there to help us train, to help us do this. But what are we doing ourselves? Sisi wenyewe tunafanya nini? What am I doing myself, as we have heard even in the what is it called, in the discussions earlier in the morning? What are you doing as a parent concerning your own mental well-being, concerning the mental well-being of your children and the people in your community? What are we doing in the churches? What are we doing in the schools? And we need to push our counties to invest in mental health, because the donors may not be here forever. And how much are the counties and is our country investing in mental health? Yeah. In the budget that they should set aside for health, they're supposed to set aside 15% of the health budget to mental health. And how much are they investing? So we need to move more for mental health.
Okay, thank you. I think the question which I was supposed to answer has been answered by my colleague. The issue was spiritual. But what I can try to add in that aspect of spiritual is that the churches, we have so many churches, okay? But at the moment, there are some councils for there's this committee or council called the Interfaith Network, which operates within the counties. So I think we always try to engage that interfaith network. We bring them on board in our stakeholders meetings and also in our technical working groups, so that we can share with them and sensitize them on issues of mental health. Otherwise, the other issue which I wanted to highlight is the issue still on integration, more so with the community health service. Now, the government is speaking too much on CHPs, and we have to empower these CHPs, and there's already mental health curriculum for the CHPs. So if we can take these people through this and capacity build them, then we shall have very much support from the community in terms of follow-up and also referral. They can also screen these clients at home and refer them appropriately. And for the facilities, which I think was also indicated that they also do a lot of referrals and they are not ably supported, we have to acknowledge that even before devolution, when we were still having the push system from KEMSA, and now we have the pool. In the KEMSA checklist, they have always been supplying antipsychotics, and most of these facilities, when you go even up to the dispensary level, you will find that most of them have these basic antipsychotics, like Lagactil, Modicate, Aten, but what you will wonder is that most of the clinicians or the nurses, or the clinicians in these facilities doesn't know how to use these drugs. You find a facility having Aten, you ask them, they think it is maybe aspirin. When they are in a dry spell, there are no drugs. Unapata mtu anapake to anything. Aten imepeana. Or they give Modicate, and without giving Aten, at the end of it, they come with those side effects. They are being treated as cases of tetanus. So I think what we've been doing and what we should try to undertake is try to orientate these healthcare providers in the peripheries in issues to do with mental health conditions. Not just even training them, but just doing a basic orientation and doing appropriate referral. Then lastly, I think we should also try to up our umbrella to involve the other stakeholders like the schools. We should also try to involve most of the issues of school nurses, school matrons. Though there are some of the individuals which really can help us manage these school students with mental health issues in school. They can also create a very big havoc if they are not really empowered. We have also involved the prison officers, the prisoners. The prisoners really have a lot of psychological issues within the prisons, and I think the prison officers and the police and teachers, I think, are some of the key stakeholders which we should also try to work with and also try to capacity build in terms of mental health. Otherwise, thank you for your time.
Thank you so much. Loud of applause for the panelists. A better one, they've done a fantastic job. I know we were rushed with time. I wish we had more time to have this conversation, but I think they've really tackled the questions that we asked them very well, and I know they would have wanted to continue with more information. I think for me, what I'm picking is the issue of capacity building and also taking up the issue of task shifting. Like Michael has mentioned, we have HTS providers who have a psychological background. Can we give them more skills, and then they help in reducing the load? And then the stakeholder engagement, having TWGs where other people can bring in their issues, their expertise, and also we are able to address more. Like when you have the church leaders, the spiritual leaders, the religious leaders, the educationists, they're able to share what is happening in their areas, and we guide and give direction. And of course, the last one of the benefits that we've picked for integrating mental health into our other programs is we are able to identify cases early, and then we also improve the quality of life for our patients and reduce on costs. And with that, we come to the end of our session. I want to really, really appreciate you for taking time to come and engage with us on these pertinent issues. And this is a conversation that is continuing. If you have any question that you feel was not answered well or would have required more information, kindly share it with Maggie here. We will look for someone to respond to your question, and we'll put them up in our website, and we can continue having this conversation. Thank you so much. Have a lovely evening, and let's go down and find out whether the sessions are going on.